Everything seems like it's working. Yeah, my name is Vincent. I'm one of the old master's students, about 2 years and a half now. But I started this master's project with Dr. Del Maestro. We had a really great year with a great group of people, and anyways, I'll go through essentially my master's project. We did different projects within my master's. I'll try to present them briefly and try to explain as much as I can. It's been a while that I haven't done that presentation, so it's gonna be great to see also, because I have a new perspective now that I'm a resident now. I'm at the end of my second year, so I kind of I went through the talk, and I definitely have more to say about certain things in this talk. Yeah, the title of my master's was Artificial Intelligence Distinguishes Surgical Skill Level in a Virtual Reality Spine Simulation. It's a pretty big title with a bunch of words that are pretty complex, so we'll try to go in, and I know everyone's at a different level, so we'll try to define every little term here so that we're all on the same page and you guys can have a good understanding. If you have any questions, don't hesitate. You can intervene at any time. And yeah, we'll start. So first of all, we started my master's project idea. It's an idea that came from the fact that, especially during that time, but even now, the times were changing in education, in residency specifically. It was one of the first years, or at least my year. So I'm a second year resident now. The year after me was the first year to have competency based across Canada in pretty much every surgical program implemented. And so my year was the second or third, just at Queen's University in orthopedics, that we were doing this competency-based curricula. For the people that are not too familiar with that curricula, it's essentially a change in practice. So usually we were doing, in our residency, we were doing a bunch of rotations, and we had objective in these rotations, but no formal evaluation. If anything, we had a discussion with the chief of the rotation at the end of, the staff that was in charge of the rotation at the end of the rotation of 2 or 3 months, and then they went through our flaws and our weaknesses and things that we could improve. But there wasn't anything really objective about the way that we were learning things. So the Royal College of Canada came with this new system where trainees would have competencies, a list of competencies. For example, you need to perform a laminectomy, you need to perform a total knee replacement, and then you would have different criteria that you need to meet, and you need to prove competency for each and every one of these EPAs, they call entrustable professional activities. And so you essentially need to prove that you're competent in a bunch of different tasks. And you can do that throughout your training now. So as an R2, I can prove that I'm proficient in doing a total knee replacement and so on. And technically, when I'm done all of those competencies that are required to finish my residency, I would be done with my residency, and it wouldn't be necessarily 5 years. It could be 4 years, 3 years. That's all the technical aspect of it, but really things are slowly changing. But yeah, we moved on to that competency-based curricula, and what's interesting in that shift was that the traditional apprenticeship model had a bunch of weaknesses, and it continues to do so. There's still some apprenticeship model within the training of our residents. It is a concern having a resident operate on someone with a staff supervising. Still, there are some patient safety issues, obviously, for obvious reason. The trainee doesn't have as much experience as a staff and could make potential mistakes on the patient. There are some costs associated with the traditional apprenticeship model of a trainee performing surgery on a real patient. The cost, there was a study actually that was done in 2016. It's pretty much the only study that I found on cost of training residents, and it showed that it was done in like Minnesota in one center, and it showed that the average time added to every procedure was about 5 minutes when there was a trainee, and that summed up to the year was about $500K for that one program at the end of the year. So it's a considerable cost to train residents on real patients. And then the resident education aspect of it is also not optimal. Obviously, you're more stressed when it's a real patient, and obviously also you don't want to make mistakes, but you won't get as much training or education if you're not comfortable doing the case, if it's a more complex case. And then obviously when there's pandemics like COVID-19 hitting you, you have less OR time. And so those are really the major drawbacks with regards to apprenticeship model. Again, there has been this paradigm shift towards the competency-based curricula, but most of the training is still done through apprenticeship model. Even if you have EPAs or competency to acquire, you need to prove these competencies in a live patient, and it still has all of these problems with regards to patient safety, cost, and resident education. So the idea was all of that. There was this shift happening. We wanted to see if we couldn't find new methods of training and assessments of residents that would be safer, less costly, and would provide better resident education. And we thought it was a perfect time to look at new things because of that paradigm shift that was occurring. So the one thing that you guys all know we have in the lab, in the NeuroSim lab, is a virtual reality simulator. And what was interesting about virtual reality simulator is that it prevents a lot of the drawbacks that the operating on live patients has. So first of all, it provides a safe environment for the resident. You can decompose the surgical procedure in many different steps, and so you don't have to go through a complex case on your own. It's pretty easy to decompose the steps of the surgical procedure, and then you can repeat the step many times until you acquire competency, or at least until you feel comfortable doing it. And then there's the potential to standardize surgical training. I guess another one of the drawbacks is that not every patient is the same, and so if you evaluate a resident on a surgical procedure, there can be different degrees of complexity depending on the patient and what happens in the surgery. So virtual reality simulators also provide the potential to standardize all that surgical training. And then the most important thing for us, what we thought was very interesting, it was that for the first time, it measures every aspect of the psychomotor skills in a resident. And so for the first time, you could actually be objective in your assessment, rather than have someone saying you're good or you're bad based on subjective measurements or opinions. So we have this NeuroVR in Dr. Del Maestro's lab. It looks like that on the picture on the right. It actually has the ability to mimic or to simulate many different procedures in neurosurgery and orthopedic surgery. And what's great about it is that not only it provides auditory feedback, you also have the visual 3D aspect of the surgery. And finally, you also have the haptics or the tactile feedback. So every different tissue you interact with are supposed to feel like the real thing, and there's a variety of different tissues. In my specific scenario that I looked at, there's about 9 different tissues that you can interact with, and you actually feel the different tissues with different pressures and different textures. So it's with all of that feedback that's provided to the user, it's actually able to acquire all the psychomotor skills components, or to record all these components in a setting that's supposed to be ultra realistic. So on the Neuro VR, like I said, measures everything. So you have every 20 milliseconds, the simulator records your force applied, the volume you removed of every tissue, the positions of your tools while you operate, and then the angles of your tools as well. So really, you have a bunch of data to deal with. And just to give you an idea, this is a spreadsheet of half of the data that we get for 1 second of one participant. So it's really a bunch of numbers that we need to analyze and deal with. And we honestly, earlier, before we were in the lab, they were doing it by hand, but the idea came with some other collaborators in the lab from Samaneh, notably, that's from Iran. And they essentially said that we could use the artificial intelligence to analyze all of this data, and it would provide us with much more ability to analyze all of that data at once, and the different variables all together and the links between each of them. So artificial intelligence, when I first came into the lab, that was the idea I had of artificial intelligence. I was a bit scared. So we'll try to, if it's the first time you hear about it, we'll try to go through it, just the basics of it, but it's not that scary. So artificial intelligence was actually introduced much earlier than we thought, than I initially thought anyways. So it was introduced in the 1950s, actually. And it's a paper from Dartmouth University that was saying that they wanted to provide the computers the ability to reason and resolve human problems. And that's pretty much the definition of artificial intelligence. Then there's often machine learning. We hear oftentimes people talking about artificial intelligence and machine learning. And what that means is machine learning is essentially a subtype of artificial intelligence. So machine learning is really using algorithms that allow a computer to learn different patterns and then make decisions without being explicitly programmed. So essentially, artificial intelligence is just trying to provide the computers the ability to make decisions or to be intelligent, and then machine learning is a subtype of that of artificial intelligence that tries to produce algorithms that allow it to learn patterns and then make decisions. And then you have another subset of machine learning. It's called supervised learning. So now it's a subtype of machine learning. So you have artificial intelligence, you have machine learning, and then a subtype of this machine learning, or these algorithms that we want to train to be able to make decisions, is called supervised learning. Now, supervised learning, you need to train the computer with data, and you need to label this data before asking the computer to make a decision. So I have a pretty simple example here to explain to everyone. If you have a bunch of apples and a bunch of melons, sorry, you would tell the computer, for example, here's a picture of an apple, or here's 10 billion pictures of apples, and here's, I don't know, like 20 million pictures of melon, and you would label each and every one of them. Different techniques to do that, but you can do it by hand if you're really keen. Then you would train the computer using an algorithm, and then afterwards you would show a new picture of, let's say, an apple, and then the computer, based on its training, would be able to identify this as an apple or as a melon. So the goal using machine learning algorithms was the goal of my project was to try to utilize this artificial intelligence or these machine learning algorithms to try to find a new way to assess surgical skill level on the virtual reality simulator that we have. Based on all the data that we collect, we would try to do that. And we used a hemilaminectomy scenario in a spine surgery scenario. For those of you who don't know, a hemilaminectomy is essentially the lamina is a part of one of the spine of the spine, essentially, and I don't know how to explain this simply, but you'll see in the next picture. The common procedure to access the spinal cord is to remove that part of the spine. So the lamina, you remove it either with different tools that you can do that, but essentially when you remove it, you only have a tissue covering it, a few layers of tissue covering it, but then you go into the spinal cord. So it is an important procedure to know how to do, because it's often used in a variety of spine surgery. It is the primary access essentially to the spinal cord. So we had the three main objectives in our project. One, we wanted to develop new metrics to quantify performance in trainees that were performing a hemilaminectomy on the NeuroVR. So essentially, we wanted to know what was important to measure to be able to assess whether someone was good or bad in that scenario. Then we wanted to use these metrics and the labels of or the level of training of some residents, and put them in a type of machine learning algorithm that's called the super vector machine. You don't have to remember that, but it is a type of machine learning algorithm. If you wanted to train a machine learning algorithm to recognize whether an individual performing the hemilaminectomy scenario was either a junior or a senior participant. And this decision would be made by a priori training of the algorithm and then testing the algorithm. And then we would use the different metrics of performance that we identified a priori to really build that algorithm and train it. Then we wanted to also train other types of machine learning algorithms to try to evaluate whether the metrics of performance were capable of differentiating the senior and junior residents. So we had a bunch of objectives. It sounded like a lot of work, and our main hypothesis was that we could use machine learning algorithm to differentiate the level of expertise in a virtual reality scenario. So essentially that we could be able to, just by looking at someone's metric of performance or the bunch of numbers that we saw earlier, whether that individual was a senior or a junior. So why did we use artificial intelligence for that? Well, as we said, first of all, we would like to make it pretty much automatic classification of the surgical skill level to eliminate any sort of bias, to make it as objective as possible. So that would be nice. It would be nice also to be automatic in a scenario where a trainee wants to train on its own and not have necessarily a person assessing him or her. But in a scenario where a trainee would want to self-train, it would be nice to have an automatic classification of its surgical skill, and then would be able to build up on his skills. The other thing with artificial intelligence is that it considers the relationship between the many different metrics of performance, whereas regular statistics don't do that as good. You know, you can do multivariate analysis, but it's just not as good at measuring these interactions and the multiple variables as machine learning. And then we wanted to, we also used the artificial intelligence because it can actually rank the importance of the different metrics in the classification process. So you can know, for example, why a specific individual was classified as senior despite another one, and you could know which metric really was the most important at doing so. So, for example, if one of the metrics is going super fast with your tool, if that's what's differentiating you, being a senior resident, if that's what making you a senior performer, then we would be able to rank that as a high importance in the metric, and it would be it would help us in determining the most important metric. Not sure that last point was clear. Essentially, if we have, let me just explain it in another way. If we have 10 metrics of different that are different. So for example, if you have like time to completion of the task, or speed, or the force you applied to the different structures, if we had all of that, artificial intelligence could also not only tell us which metrics are important, but which one is the most important of them. And you'll see how this goes on in our study. But essentially, you could have, for example, that the force applied was more important in making you a senior resident compared to a junior resident. So all of these reasons were pretty interesting to use artificial intelligence. So then we asked ourselves what was done before. And that's where we went to the literature. It's always good to do when you start a project, to just go have a look at what's out there. Surprisingly, there were about 12 papers on using artificial intelligence or machine learning algorithms to assess surgical expertise in virtual reality simulation. All of them had a lot of drawbacks, and that's what the article, we did a review article essentially outlining what the drawbacks were and what we could do better. The way we did, we had a bunch of so we had 2 people review these 12 articles with a set of questions that was a priori determined by our group of people with different areas of expertise. So we had a computer scientist involved. We had surgeons, obviously, and people that were strong in education. So we all regrouped. We went through a bunch of questions, or a bunch of things that the papers that were presenting the use of machine learning to assess surgical expertise should have in their articles. And then we went through all these questions. And what came out of it was that the 12 articles were really not standardized in any fashion. Most of them were not normalizing the metrics of performance, which we thought was a very important thing to do. Essentially, you need to put every metric of performance, or every number, on the same scale. If you have, if you're looking at force applied and it's in Newton, and you have 10 Newton comparing to 1 Newton, versus speed, and it's like in meters per second, and then you have orders of difference of 0.01 versus 0.1, then you for sure need to put them all on the same scale so that you're comparing the same things. And most of the papers did not do that. The second thing was that most of the papers were not describing the metrics that were utilized to train their algorithms. So they were not saying what was used by the algorithm to make its decision of whether the surgeon or the trainee completing the procedure was a senior or not. And they never, or very rarely, did they include the educational rationale of their metrics. So when they did describe which metrics was utilized by the algorithm, a lot of them were not very intuitive, and they weren't providing any educational value to that metric. So for example, if you're looking at a metric of speed, you need to explain why that metric would be interesting in an educational aspect. So how could you train speed? And then how could you say that speed is effectively important in the surgical expertise. You need to explain that if you really want to make it out there in the educational world. And then the other thing was that most of them did not explain the methodology of training and testing their algorithms. There's different things that you can do. There's like cross-validation, other stuff that you can do to train your algorithms and then test them. And you need to be pretty explicit about the way you're doing things, because your results can be very good, for example, if you didn't test them in a separate, completely independent data set. And so you need to explain that in your methodology, and most of them were not doing that. The other thing, most of them were not providing sensitivity specificity, which is pretty important, specifically in the medical world. We thought it was very important to include that. And then the last limitation was that most of them did not provide any limitation of their machine learning algorithms or methodology. So there was a lot of things that we needed to work on. And when we did our project, we really focused on all of these specific components and tried to describe it as best as possible. So we recruited a total of 41 participants. Then we labeled them as senior or junior based on their level of training. So there was 6 spine surgeons, 3 spine fellows, and PGY 4s and 6 of orthopedic surgery and neurosurgery were one group altogether. They were the senior group. And then the junior group was medical student and junior residents, PGY 1 to 3 in both orthopedics and neurosurgery. And then we made them do the procedure that you're going to see. So they had 5 minutes to remove the lamina. The lamina is the thing that you can see here. It's part of the vertebrae. And this is the spinous process here that you can see, the interspinous ligament. And essentially that part is the thing that you want to remove with your drill while suctioning out the blood, or feeling with your suction if you're actually going through bone, or if there's still bone to remove, or if you're in the ligament inflavum. So they had 5 minutes to do that procedure. And then all of their data was recorded when they were doing that. Sorry. So then that's the part that we did. So I don't know if you can see my mouse. Anyways, so the data acquisition is what we just saw. The people were doing the procedure, and then data was acquired. As you saw previously, all these numbers in the big picture I showed at the beginning, the 1 second of one participant, that's the data acquisition part. Then we went through a variety of steps and to essentially to find the metrics that were the best, and then to train our algorithms with these metrics to say if the resident was a junior or a senior. And then we went on to select the best algorithm. So different types of ways that we use to select the metrics, because you come up with this giant Excel table. So then you need to really narrow it down to the most important things. And to eliminate the noise, essentially. So the first thing we did was extracting the data, essentially making sure that there was no errors or numbers that were essentially like blank, or a case that was blank. Like if an individual didn't touch a certain structures, we needed to remove all. Then we went on to normalizing the metrics. So like I said, put every metric on the same scale, so that you're actually comparing things that are on the same scale. Then we went through 2 spine surgeons, and we gave them a bunch of metrics that could potentially differentiate a senior from a junior. So for example, for supplied on the dura, the volume you removed of the lamina, and all these things. And then based on that, they selected a few metrics, and then And then after that, once we had these metrics selected by spine surgeons, we actually used an algorithm that was trying to combine all these different metrics using a machine learning algorithm and trying to find the best combination to be able to differentiate seniors from juniors. So our metric extraction, like I said, consulted with expert surgeons. We used metrics that were published in the literature, so from the 12 articles that we saw, and then we coded new metrics. So like I said, we needed to remove all the things that were like empty, essentially. But we also needed to create a different combination of or create the metrics, so different combination of the data. So for example, you have the position in X, Y, and Z, for example. To find out the speed, you need to do the position on time, right? So we needed to code that to come up with metrics of speed, for example. And so that's the work of the metric extraction. So use the expert's opinion, previously published metrics, and then we used some of the metrics that just made sense to us that we thought could potentially differentiate between people. And so we coded all of these metrics. Then we used, like I said, two independent spine surgeons to select the metrics that were more educationally understandable, if you will, or that you could actually teach someone to, or that they thought could differentiate two people between a senior and a junior. And then we used what's called a backward selection algorithm, which essentially starts with all of the metrics that were selected by the two spine surgeons, and then gradually removes them one by one, and then calculates the performance, and then repeats that a bunch of time until optimal performance is acquired for your algorithm. So that's an example of the support vector machine. Essentially, this looks pretty simple. It's just a line that's drawn between the two groups. So here you would have your group of seniors. Here you would have your group of juniors, and then you have your line that separates them. And with the support vectors that are those two lines that are used to essentially make sure that both groups are optimally separated. It looks simple on that picture, but when you think about it, it's a bunch of different variables. So here it would be only two variables together, but you have to picture something. For example, if you have 12 metrics that you're going to analyze, it's going to be in 12 dimensions. It's going to be a hyperplane. It's not going to be just a simple line. So it is a pretty complex algorithm, but it's one of the most simple machine learning algorithms. The rationale behind it is kind of simple to understand. What we used was to validate and to train our algorithm and to test it. We didn't have big numbers, so we needed to do cross validation. So essentially what we did, instead of using a group of people, train our algorithm on it, and then use a separate group of people and then test the algorithm on it, we used our 41 participants, and then we trained the algorithm to recognize, we trained the algorithm with like 40 participants, and then tested on the one participant without telling the algorithm whether this was a senior or junior. And then we repeated that for every participant. So we repeat the process 41 times. So so we were actually able to generate more than 1,000 metrics just by using different combination, removing metrics that were empty, and just with our the literature that we went through, generated more than 1,000. Then 41 were selected as intuitive metrics, or metrics that could be taught, or metrics that made sense to the spine surgeon, and that were potentially able, according to them, to differentiate between a senior and a junior. Then we used those 41 metrics, and then I'm sorry, we used 41s that were thought to be educationally reliable or educationally intuitive, based on our understanding of the metrics and metrics that could be taught. Then we used the spine surgeons to select within those educationally intuitive or metrics that could be taught. And they chose 36 of these 41 metrics. They chose these metrics based on the fact that they thought these could differentiate between experts and non-experts surgeons, or senior and junior in our case. And then we inputted these 36 metrics that were selected by the spine surgeons. So the 36 metrics in the end were generated by us. They were thought to be educationally intuitive, so metrics that could be potentially taught to. And then they were also selected by spine surgeons based on the fact that, according to them, in that specific procedure, these were the metrics that could be differentiating between a senior and a junior resident. And then we inputted those metrics in our selection algorithm, and the algorithm chose a combination of 12 different metrics to have optimal performance with our algorithm. What's interesting is that we were able to classify the metrics in 4 different components of the surgical skills. So for example, we had one safety metric, the maximum force applied on the dura with the burr was one of the safety metrics that was helping to differentiate between senior and junior with the combination of the other metrics. Then there was a motion metric. So for example, the variance of your pitch angle of your burr when you remove the L3 lamina. Seems very complex, but essentially it's just that sweeping motion when you remove the L3 lamina appeared to differentiate seniors and juniors. Coordination was also something that appeared to influence the algorithm. And our example of metric for coordination was the amount of time you were spending while using both the suction and the burr at the same time. And then finally, we had one efficiency metrics, which was the amount of time spent removing the L3 lamina on the total time to completion of the procedure. So we had a total of 12 metrics in total, separated in 4 different categories of expertise that the algorithm chose. These are all the metrics that we had, and essentially we did a ratio of senior on junior to understand more what it meant for each different metrics, or how to understand what does a senior do that a junior doesn't do. So for example, here you can see the force applied on the dura, the maximum force applied on the dura, which is a structure that you really don't want to injure. It is the sac that's lying on top of the spinal cord and recovering the spinal cord. So you can see here that the senior residents appeared to apply much less force compared to the junior residents, and hence were probably more safe in their way of handling soft tissues. And when they got close to the dura, they were probably more careful in applying less force. Potentially, more force applied to the dura could lead to a dural tear, and then there's a fluid, spinal fluid that comes out, and it causes a headache, and it's a complication. You need to have your patient bed rest for 72 hours, and it's really not fun. So potentially that's a metric that could be worked on, and it is certainly a safety metric. Then if you look at the efficiency metrics, so like we said, the amount of time spending removing the L3 lamina to the total time to completion seems to be relatively the same within senior and junior. When you look at the average, the ratio is pretty much 1. But that's where it gets interesting, is that the algorithm doesn't just look at the average of everyone. It looks at a specific participant and looks at every one of those 12 metrics, combines them, and then decides whether this person is a senior or junior resident. So that's where these results get interesting in the way that you need to understand how your algorithm works. It's not simple statistics. It's really a combination of the different variables. So I thought it was interesting also to present that aspect of it. And then I won't go through each and every one of them, but there is a lot of interesting stuff happening. Obviously, it appears that there's a lot going on in the motion of the tools that differentiate between the senior and juniors, and a lot had to do with the consistency of movements of both the burr and the suction. So it seems to be more consistent when you're a more senior surgeon, which makes a lot of sense. So with these 12 metrics, trained using our leave one out cross validation, so repeating the process 41 times, the algorithm only made one mistake, classified a less skilled individual or junior individual as a skilled, classified a skilled individual as a less skilled individual. It only did that once, and that individual was really like on the verge. When we looked at the result, it was interesting because it was really on the verge of being a junior resident. Interestingly, the individual was, if I'm not mistaken, a PGY4. So really on the verge of being labeled by us as a junior resident. So you can ask yourself, did the machine do the mistake, or did we make the mistake of labeling him or her as a less skilled participant? Those were all the machine learning algorithms that we went through. Essentially, you can see that there was some consistency. The algorithms did pretty well. The reason why we looked at other algorithms is also because we used the backward algorithm that we used to select the metrics was a bit biased towards, was actually biased towards the super vector machine algorithm. So we just wanted to see if the metrics were truly good just for the support vector machine, or if they were good with other algorithms too. And it seems like they were good with other algorithms. Obviously, they were less performant, but they were pretty good altogether. So the key takeaway here is that machine learning algorithms can potentially be used to differentiate level of expertise in virtual reality scenarios, and that could be huge for surgical training. As we said, it would provide more objective assessments of surgical skills. You wouldn't have necessarily someone assessing you, but you would have objective measurements, really. Your speed, they're all like your force applied, they're all numbers that you can't argue against. Then there's the potential to use the metrics and the algorithm to build potentially a feedback platform. So like I said earlier, you could have someone that wants to self-train, do the procedure on your simulator, and then have the algorithm assess them based on the metrics of performance that they had for that particular performance. And then we could have, for example, the simulator show which metric the resident or the trainee did well and which one he should improve or she should improve. So that could be interesting in a teaching environment for sure, or in a teaching hospital. For residents, that would be amazing. And then the other thing is that it could very well complement sorry, there's a little mistake here. It could complement the new competency-based curriculum for sure, because you could see, and we're working on that at Queen's, to have actually EPAs or entrustable professional activities that could be completed, or that should be completed on simulators before you go and operate on real humans. So that would be a much safer way of training people. there were some limitations to that study for sure. Sample size is always difficult in these types of studies. Recruiting surgeon was really hard. Thankfully, we had a lot of help from a bunch of different people and residents. You know, they're all busy, but we were able to recruit quite a few residents and surgeons. But nonetheless, our sample size is pretty small. At 41 participants, it is really small, and hence the reason why we use leave one out cross-validation. If we had more participants, we could potentially do a completely separate data set and have more robust results or more reliable results in the general population. Then there's this whole discussion about defining expertise that is very hard in these types of studies. You know, we chose to define it per training levels, and the reason we did that is because we didn't have the competency-based curriculum was not implanted yet. So we didn't have, for example, if we did that study now, it would be a bit easier because for example, one of my EPAs or entrustable professional activities that I need to do in my curriculum right now is to perform a laminectomy. So you could have, you could define expertise by saying these people here passed the EPA and based on a variety of different surgeons have the competency in a real human being to perform a laminectomy, so they should be deemed competent. And then you could have another group that didn't pass the EPA yet and that's non-competent. So it would be easier now to define the expertise as such. But we were stuck with training levels because of the previous curriculum in residency training in Canada. Nonetheless, we asked participants how many laminectomies did they perform. You know, it's not an optimal way. It's oftentimes it's hard to remember how many laminectomies you did or how many cases you did, but we had a general idea, and the groups that we did, the way we separated it into PGY 4 and above and PGY 3 and below, there was a pretty clear cutoff between those participants, and almost all of the PGY 4 and above had performed more than 20, and the PGY 3 and below had performed less than 10. So, you know, we still did quite a lot of efforts to try to define expertise. It is pretty hard, and it is one of the limitations of the study. And then the simplicity of the surgical scenario is also part of the limitation of this study. It has been validated in the previous studies and show that the scenario is realistic, or is somewhat realistic, and somewhat close to the real deal. But it is a pretty simple scenario. You had 5 minutes to complete the task. It requires a simple, use of a burr and suction. So obviously, it is a pretty simple surgical procedure. And then the fact that we did leave one out cross-validation and we didn't have an independent test set was also one of the limitations. You could argue that the results will not be reproducible with a separate test data set. So for the future, what we originally wanted to do, and it's been 2 years since we had these future directions, so there's a lot of stuff that has been done, but we wanted to test the accuracy of the algorithms on a completely independent data set. We tried doing that. We had really a lot of troubles recruiting participants again. We tried doing that. The results were, it was hard to say whether the algorithms was working or not, mainly because we had a lot of medical students to test it on, but not a lot of spine surgeons that came by. So it has been hard to recruit spine surgeons to redo that similar procedure. So we sort of recruited all of them for the first part of the study, so it was hard to recruit a completely independent data set. But anyways, that would be an interesting study to do to see if the algorithm actually works in a different data set. Then we would like to try a new method of metric selection. So a new algorithm, like I said, ours was pretty biased towards a super vector machine. There are other ways to select metrics. Would be interesting to do all these stuff. Now I won't enter into, I feel like I'm confusing you with all the new words, but essentially one class learning, unsupervised learning, those are different types of machine learning algorithms. ANN is artificial neural networks, another type of machine learning algorithm. So we could use different ways of selecting the metrics. And then after that, build and test the automated platform, feedback platform that we talked about. This is what it looks like. This is a paper published by Nikan in Plus One, where he explains, he essentially built a prototype of what it would look like to have a machine feedback system. So you would do the procedure. Hopefully you would classify as a senior, but if your metrics say you're a junior, you would be classified as a junior, and then the machine would explain also in the different components of surgical skills, like, for example, safety, coordination, where you stand compared to the senior group. So that would be the senior group here, and that would be the junior group here. And then you could see you need to improve, for example, in that scenario, that person would need to improve its safety metrics, so would need to apply less force to the dura. So the next time that the trainee is doing that procedure, they would probably be more cautious about the force applied to the dura, and hopefully get better results. Remaining questions, and it's going to be hard to do studies on this, but what's the learning curve on training on the automated feedback platform? If it works better than the regular current training that we're doing, the apprenticeship model of doing one case in the OR and then doing another case in the OR, if the learning curve is actually similar on a virtual reality simulator, provided with automated feedback, that would be an interesting study to do. And then the skills learned on virtual reality simulators, are they transferable in the OR? That's very hard to do. There's a few studies actually that show that it is transferable to cadavers, for example. And there is, for example, my program director did a study on arthroscopy, shoulder arthroscopy, and teaching medical students how to do it. And according to his experience, from what it's worth, he said that with like 30 hours of training on the surgical simulator, they were better than an R3. So that was sort of interesting. So I think it is probably transferable to the OR. We just don't have the proof yet, and I think that's where Alex PhD is trying to go to. Anyway, so thanks for listening. It was a long presentation. I'm sorry. I hope you all understood, and I hope I made my different points clear. I know it's a lot of new words, and it's a pretty complicated subject, but it's really interesting, and I think it's pretty cool to have computer science help out with education and surgery. Yeah, so this is the team I've worked with. I'd like to thank Dr. Barry and the Division of Orthopedics for the funding of the master's project, and obviously Dr. De Maestro as well for having me on board for such a cool project for a year.